Yeah, I mean, I could not think of.
Good evening, everybody. Thank you so much for being here. The Neighborhood Health Series. This is the last event that we have until we go on break for the summer, and then we'll be back in the fall. So you should have the schedule there. We are recording this, and this recording is always posted to the website, so you can always watch it back if you have any questions or things that you want to listen back to. And we have our friends there on Zoom from other campuses and other places around the world joining in. And so this event was really created 10 years ago, actually. It's been 10 years to help establish community here in Summerlin, to bring our community members into Roseman and give them an opportunity to really be empowered with healthcare facts and wellness facts. And so if you imagine we do 9 of these a year times 10, we have done 90 of these actually. And I myself have learned so much in all that time. What's wrong? Something wrong? Huh. Feedback. Feedback. Okay. All right. Got it, Vicki? Okay. Is that okay? Still feedbacky?
Sorry to interrupt, but have you started?
So that's a big approach that we take there and focus on those areas. We do a lot of interaction.
The cultural competency to provide healthcare to their community. Now, one of the ways that we have done this is really to take the Roseman model at large and look at how that applies to the medical school experience and education. And I think it's something very innovative that we're doing, really, because for the large part, we're going to be starting out with students having very early on experiential learning where they're going to go out into the community, into homes through our Genesis program. And they're going to be able to really understand very firsthand the realities of when we talk about social determinants of health. It's not just something they're going to be reading in a textbook. They're really going to understand the reality of what healthcare means to a patient. Because at the end of the day, you go to the doctor's office, get a prescription. That's not the beginning and end of your healthcare. There's so many other factors that sort of factor into that. And so part of the way the curriculum is designed at College of Medicine is really to keep that as the focus. And then being in, the community here in Nevada and the local Las Vegas area, we have the opportunity to partner with so many local community partners that offer our students just a wide variety of experiences that really will expose them to really the lived reality of the people in their community. And hopefully that will really help us to create a physician workforce for the state of Nevada that will really be able to deliver healthcare, not just in Nevada if they go everywhere else, but our focus really is to improve sort of healthcare within the valley, right?
I appreciate all those answers. Those are great. So I'm representing the College of Pharmacy, and I'll just talk about what I did today. I was in the classroom all day today with our first year pharmacy students, and I was teaching them kind of their introduction to literature evaluation. We looked at studies going in a particular area, heart failure with a reduced ejection fraction. It's one of several disease states we cover, but in this one area, we looked at studies going as far back as 1987, 1985, all the way up to like 2021. And these studies have kind of, I guess, directed how our guidelines are built and how we treat this particular disease state. And one of the things that we look at when we're trying to evaluate the literature, it's like, is this applicable to our patients? And as you looked over that same time frame of nearly 40 years, you're looking at largely white male populations. Now, sometimes that's fine because the drugs might work the same in a black female versus a white male, and that's totally fine. But sometimes there are differences, or sometimes we just don't have enough data in those studies to know if there are differences or not. In explaining this to the students and introducing to these concepts early in the curriculum as they grow, I think is really important because sometimes it matters, sometimes it doesn't, and they're going to have to be able to kind of figure that out. Through our didactic curriculum when they're in school with us and we're teaching them all the stuff about the drugs and the medicines and the disease states, that's one way we can do that. That's all technical. The difficult part really comes, I think, when we start talking about the soft skills. How do I interact with a patient who has a different background or who might not have a particular access to medications or healthcare at a different level? And that's where I listed some of these things. Our community partners are outstanding. We also have really great student organizations that do outreach events in the community, particularly to underserved patients here in the Las Vegas area. And that's another way we kind of expose our students and get them out talking to this, seeing this stuff firsthand. And it's really, we're blessed to live here in such a diverse area of the country where our students are able to kind of see that a little bit more readily. Previously, I taught in Maine, and Maine is a considerably less diverse population than it is here. And so that was even more challenging there. I think that we're really blessed by our location in trying to meet this new initiative, I guess, and trying to meet healthcare for a diverse population.
Yeah. You actually kind of touched on some things, Dr. Williams, that I want other folks to kind of chime in. You talked a little bit about how are we delivering culturally competent care by having our students engage in some of these activities. But does anyone else want to kind of talk about how they are specifically preparing students to, and Dr. Akinyi, you kind of touched on it as well, talking about how do we get our students to really understand health disparities and the impact that it has on the individual and their families, as well as how can we ensure that we're teaching them to be culturally competent in their care, right? Is this, oh, read a book. There's a chapter on this in your textbook and we're going to test you on this. Like, how are we doing this? How do we ensure that at the end of 3-4 years that they come out and I'm not going to say they're not going to be biased, but their biases are substantially reduced or minimized, right? Because we all have these biases. So what are we doing? We're just going to go like a wave.
Right. I can start. I briefly said, we have student organizations that are doing outreach. I think part of this actually goes back to who we're bringing into the college and what our students look like, and having, kind of more of a holistic approach to admissions. There's very little that can substitute for lived experience. And when you have a student coming in who's from a particular background, who's lived that life, they're able to connect oftentimes a little bit better with some of the patients that they might see that come from that background. And that's nothing bad. I mean, that's just the reality of it. And through our curriculum, we try to do our best to acclimatize everybody to whatever patients they might see, be culturally cognizant as they go in there. But I think part of it is understanding that there's going to be patients that I don't relate to, and there's going to be patients that don't relate to me for the same reasons. And that's fine. I got to do the best that I can. We have to provide the opportunities to train our students as best we can so that they are approaching that with humility and they're able to kind of get a good outcome for our patient.
Love it.
Yeah, I love the fact that you mentioned how, even, the holistic admissions in the class, but also the faculty. And it's very funny because if you have a diverse group of students and faculty, you actually make each other more culturally competent, right? So you yourself become more culturally competent being exposed to working with people. So you might not have the same kind of instantaneous rapport, but you actually start learning the skills about how to actually interact in that environment. At College of Medicine, we're actually very deliberate about this. So everything from our simulation experiences are designed to make sure that, the students have these opportunities to get things wrong in a setting where they can sort of improve before we foist them on patients. But in the simulation experience, we're very deliberate in making sure that we have this sort of range of diversity. Even going as far as making sure that our mannequins aren't all just, what would we call it, like carton colored, right? Like, so we have a variety of shades for our mannequins and Band-Aid color, there you go. And then we think through at each of the different sort of stages of the curriculum. And that involves our Roadrunner community sessions for the students where they will have the opportunity to really explore these in depth. We have a lot of humanities embedded into our curriculum for the sake of building up not just cultural competency, but also ethical practice, and sort of, having that understanding of the reality of the human experience, and sort of weaving that in. And we don't just have physicians as part of our faculty, we actually have people who know these things and have really studied these things, and really bring to the student experience a perspective that I think is really invaluable. Even our professionalism curriculum and our professional identity formation process is so very well defined and incorporates opportunities for us to kind of think outside the box about what it means to be a professional. And we do this not just for the students, but even for ourselves as faculty, right? Because at the end of the day, the professional identity formation of our students is driven by the faculty, right? Like, we do sort of, if you want, embody what we want our students to become. And so if we don't model appropriately, then we're not going to be able to have them go out in the world and be the physicians that we want them to be. So the deliberateness with which the team has put together, the faculty, the School of Medicine, and just in Roseman in general, I mean, it's just been very impressive and really great to see, and excited to have the College of Medicine come into this larger ecosphere of Roseman University.
And I agree with all of you that, all of this is threaded throughout all of our programs. Both of you, all of you have commented on that, and just a lot of similarities. So in our simulation and labs, we also thread cultural diversity and actual simulations where we do role playing with our nurses, and they understand situations and give them, assignments that in the simulation lab that will help them with that process. We have also several other things that we do where we have case studies. And again, those are didactic things, but we can do the case studies in the labs and then ask the students how do we deal with this? What's the best way? And then just getting the feedback from everybody. I'm also the Global Health Faculty Advisor, and I have been on several mission trips, not only for this school, but at another college I worked for in Colorado. But to me, when you go on global health trips, those are usually life-changing trips. And you get to see firsthand facilitators and barriers to healthcare throughout in different countries. For example, I was recently in the Philippines with the nursing students, and I know it was more life-changing for them than it was for me because they saw firsthand what was lacking. I mean, the patients were 4 hours away from any kind of health care. And so when we brought them medications and health care, and we also worked with physicians, and I'm trying to remember if I think we maybe had some pharmacy there as well. And so it truly makes a difference. And you can also see how, when people come here from other countries, firsthand what they are going through and what a culture shock it is to initially come here. And today, and I liked how you spoke from what happened today. So today I had a meeting with the Global Health Nursing students, the board, and we're trying to decide where to go next and where we could make the most difference and what we can bring back to our courses and to the other students. We also want to work interprofessionally with other departments as well. And I know Dr. Thacker has been very interested in doing that. And so we were looking at different countries and what could make the most difference for us to be able to understand different cultures, different perspectives, and how it will help us give better patient care.
Yeah.
And again, it's the interprofessional aspect that we're looking at as well. And we have an IPE program that I think pharmacy has been running. And so I don't want to speak too much to what you've done with that, but I know nursing now is going to be looking at it for the next year. And that's the interprofessional education program where we do look at different cultures and cultural competency. So that's from a nursing perspective.
What was the question again?
Yeah. Can you change the world in 30 seconds or less?
Fluoride, that's all it takes.
Okay.
So-
Yeah.
It was, so the way that so dentistry is kind of unique. We're very procedural based healthcare profession. And so, and with that, we're kind of afforded also in a dental school, our patients are just natively, they just happen to always be patients that are usually having issues with access to care because we're a third the cost of any other private practice clinic in the state. And so it's easy to get students exposed to it, but honestly, it just simply comes down at the end of the day is reminding the student or the resident that there's a person that's attached to the root of that molar, just FYI, and believe it or not, it's sometimes very difficult to get people out of that mindset, especially when they're coming from, for dental school, you go 4 years undergrad and then, well, it used to be only 4 years dental school, but now we're a 3-year program. But they're just, their heads are in books the entire time. They do outreach, they do community service, but it's, they really get separated from that human aspect. So it's honestly just as simple. It sounds simple, but it's really not. But just getting the student or the resident or even the faculty to sit down and actually just talk to this patient and forget about the teeth for like 2 seconds, right? It's just sitting down, building that rapport, getting to know them. Because at the end of the day, you'll never know what, disparities or any kind of social barriers that they might run into if your patient doesn't trust you enough to actually sit down and talk to you. So
Yeah.
it sounds super easy, but it's not.
No one said it was easy, but it does sound easy. We're going to switch gears a little bit. We're going to talk about some of the fun things and technology and advances that all of our respective areas have made over the past few years. Now, I'm a little biased right now, just only because the College of Medicine just hasn't quite opened up yet. But I was a little jealous of the whole dental scene, the clinic, and all the things that are going on in that wonderful clinic. So, my understanding is that you were probably spearheading a lot of these technological advances. So talk a little bit about that and the role of these advances, AI, all of the things, and how you're sort of integrating that into the curriculum and using it, and what do you see down the line?
Question. I could talk forever about that. I won't, I promise.
Don't do that.
But the college, luckily I work for a dean who I really admire, who's very forward thinking, and we're always trying to make sure that we're curating our patient or our student experience for the practices that these students are going to work in when they get out. And right now that's all digital based, and so when we're hiring faculty, when we're choosing different systems to come in the school, it's all based on what is kind of the forefront of dentistry. And so a lot of that is, anything, we're doing a lot of 3D printing. We're 3D printing crowns now that are just as strong as a lot of the lithium disilicates. We are doing completely computer guided implant surgeries with surgical guides and making 4 millimeter incisions to be able to place these implants. But I guess the biggest one that is really the one that is everybody's kind of got their eye on is AI for good and bad reasons. And so the good reasons, is when you're reading, for example, dental radiographs, x-rays, or you're looking at a cone beam computed topography, like an actual head CT, there's a lot of variability in how every provider looks at that and interprets that. So if you take like 1,000 dentists, getting the same x-ray, you're going to come up with 1,000 different treatment plans. Just how the subjectivity of the radiograph reading happens. And so with that AI, we've incorporated 2 different AI systems into the clinical practice that we're going to be starting in July. One is Overjet and one is Pearl, which they integrate into our electronic health record system, and they will actually scrub the entire patient record looking at bone loss levels to find missed diagnosis of periodontal disease. Somebody might have gotten scheduled for a normal cleaning and really needed a deep cleaning, and that got through. Now, the bad side, which I know we were talking about fun stuff.
Well, we can talk about the good, the bad, and ugly.
Exactly. There's a lot of visibility of this same AI technology and these same companies being integrated into insurance company claim processing. And so, the question, and if you want to get into the real ethical part, is, there's obviously an algorithm that determines whether or not they're going to diagnose something a certain way, or label it as an approved treatment for their insurance plan, and who determines that? Who pays, maybe it's the one who pays the most money for the program. That's really a question that I think, we need to be asking.
Yeah, that's a good question. What's
That-
going on in nursing?
Well, let me just comment. That's very impressive.
Yeah.
And I've been in your clinic, and so that's just, you are miles ahead. In nursing, so the faculty have started to use AI to kind of help them teach better. Not kind of, but to help them teach better. And we recently had our annual retreat where we had one of our faculty talk about how to use AI to develop better assessment questions, exam questions, and to help simplify things or help connect the dots for the students. We've also been working with our instructional design team that has different products that we can use in Canvas for the students. There's something called H5P, where it's an interactive program that you can put in Canvas. It can help develop interactive PowerPoints. It has interactive videos in it for the students. It also has interactive, something that recently one of our instructional design people, Robert Lloyd, showed us. Where you can do crossword puzzles where you answer the questions. And, if you're into that kind of thing, which it helps me learn too, AI, I do see a lot of positives with it. And we're learning a lot from it. And what is the question for the future of AI?
Right.
One of the things that I recently read about was that one of the first nurse robots was implemented in Hong Kong, but there's some issues with it about them getting around and that sort of thing. So, we talk about what is the future, and, like to hear the students' feedback because it's happening really fast, and we're doing our best to keep up with it. And so I just am excited to see what will happen in the future as well.
Yeah, great. Thank you.
So AI has been something that I'm biased about because I'm very much of the, let's embrace this. And thankfully, a lot of folks at College of Medicine have also always been that way as well. There are going to be upsides and downsides. I think the question of what's the future of AI, the honest answer is we have no clue. Because if someone told you 3 years ago that AI would be capable of the things it's capable of today, you probably wouldn't have thought it would happen this quickly. And basically, every 10 months, the capabilities of the publicly available AI systems are just increasing exponentially. I was in San Francisco recently. I got the opportunity to drive in a Waymo. I hailed a cab, and a car showed up, and I opened it, and I got inside, and I said 10 Hail Marys. And it was... yeah, it was an experience. But I could tell you that that car drove better than any driver I've ever been in a car with. And I remember everyone telling me stories about how when those cars first came out, they were kind of stupid. And, they get stuck and, they wouldn't be. This car was driving, it cut in front where it needed to. It stopped where it needed to. It was impressive what it could do. So when we think about, like, what does this mean for medical education? As an educator, but unfortunately, I can't tell any stories about, like, what I did today because, I was moving office buildings because our students are still going to be here in a couple of months. But as an educator, I think one of the things that AI has done is it has really challenged us to rethink the ways in which we educate our students in a certain sense. Because if you think about what the college experience was like, right, for most of you in the room, or for most people who went to college a while ago, before AI, right, I shouldn't say AI because it's really pre-language, large language models, right? Because AI is, a concept that really started in the 50s, and yeah, so it's a long process in machine learning and things like that. But when we talk about the large language models that have really changed the way the college experience is, you can't tell a student, like, oh, here's an assignment, go write a reflective essay, right? because, you know, chances are there are ways to get around being able to do the assignment, or AI is able to help the process in a way that's actually detrimental to the process of the students learning, right? And so schools have kind of had the discussion about, well, what's your AI policy? You know, and in College of Medicine, we're thinking about what's our AI policy going to be? What are we going to allow students to do? And so one of the things that we've been thinking about really deeply is how permissive to be with allowing our students to use AI. Now, the reality is AI is out there. They're going to be working in a world and an environment where this is just the reality, right? And so instead of, at least as an educator, and a lot of educators, College of Medicine kind of fall along the spectrum, as an educator, instead of trying to fight against that current, what we've had to do is challenge ourselves to think about, well, how can you make your learning process more valuable, or like use the AI itself to make the process of interacting better. So one example I'll give you, for example, is I created with our Dean of Simulation and a GPT, which is a subset of an AI, that is literally able to recognize the state that the students are in. So say they're in their cardiology section of their course, and they want to practice, it can simulate patients with the cardiology disease that they would have seen up until that point. And so they can have a patient interaction. You can actually have an actual conversation. It was so funny because we had presented this at a conference a year ago, and one of the feedback at the conference, oh, it was so great if your model could have a voice-based conversation. 2 weeks after that, it could. Right. And so now we have this where we could give the students the ability to practice. So by the time they come in for their practice simulation with the standardized patients in our simulation center, they can already practice at home as much and as often as they want to. So we're really having to rethink assignments in ways that we allow the availability of AI to really help the student improve their own studies, right? Now that means we can't get away with giving lazy assignments, right? Where you're just like, all right, give them an assignment, let them do some work, and then we'll grade it and have conversations later. Because sometimes that might not be quite as meaningful, right? So we're sort of challenged to think about, well, what do you want to get out of this? And what's the critical learning piece of this? And how do you create an exercise or an assignment for students that even if they were to use AI, there would still be critical thinking that they would have to do, that the AI, for now, is not quite, you know, smart enough to do on their behalf.
Wait till tomorrow.
Now, the larger view, though, right, and this is part of the reason I have the bias of, you know, affinity towards AI, and that's twofold. One is what AI is already doing, and actually was already doing even before the large language models for medicine, right? Because everything from how we read radiograph, like Dr. Tacker mentioned, to a whole lot of imaging, cancer, tumor recognition has been done by language, machine learning and sort of AI models for quite a while in medicine. One of the reasons why I'm really excited about this is because of what this will be able to do for access to medicine. So think about like one of the projects that our dean is hoping to work on at the College of Medicine is a technology that's able to take a two-dimensional rendering. So say, for example, we take a chest x-ray, and it can take that chest x-ray, which is easy, it's accessible for people even in rural communities or in underserved areas or in the Philippines, right, to have access to a chest x-ray. And it can interpret that in 3D dimensional data. And for example, recognize or predict that you're about to have an aortic dissection, or like you have an aneurysm that's forming, right? And it can detect this through a test that's easily available, you know, and you don't have to come in for a CT or something more sort of costly that you might not have access to and things like that. So there's a lot of that medicine's going to do. The other piece is part of the reason why I think our institution at Roseman is going to be phenomenal in driving the conversation for the future, because it's going to be, there is value to a physician beyond just the medicine that a physician provides. There's value to a nurse beyond just, her actual actions providing you the medical care that she's providing you, right? And that is where there is a humanistic, the art of medicine, right? Not just the science. And that art of medicine is one of those things it's not necessarily as easy to transmit, but I think it's going to make us be more deliberate in transmitting it, because the value of that art of medicine, the part a computer cannot do, the nursing that a robotic nurse will never be able to achieve, the comfort it can't provide, the reassurance it can't provide, all of those things are going to matter so much, right? And so that's sort of one of the greatest things about AI, is that it's honestly in some ways going to make us turn inwards to value the things that actually make us human. And I think it's going to lead in many ways for potential for a much better society. We're just always going to constantly be at crossroads over the next couple of years and decades as this comes out. And hopefully Roseman will be at the forefront of leading the conversation in the direction of the humanistic aspect, so that we harness it in ways that actually really make society a better place and make our communities better. Sorry, that was long-winded.
This is very
You
good.
can tell I'm not passionate about this at all.
No, between you and Thacker, I don't know. Y'all can duel it out later.
Within pharmacy, one of the main areas I think that our technology pushes it forward is in the realm of information. Nobody can know everything about all of the medicines and all the disease states, yet pharmacists get a lot of questions about these things, very commonly from nurses, from physicians, from patients. And you have to know where to go to get that information. In my pocket, I have, I think, iPhone 16. When I went to school, to pharmacy school, I was in school when iPhone original came out, okay? And all of my faculty, they didn't have access to these types of things when they were teaching us. And so it was really almost memorization based for like, what's the metabolic pathway for this particular drug? Because running a big drug interaction checker, we didn't have like really the technology to do that readily. And now when I have iPhone original even in my pocket, I'm able to do that kind of from anywhere. Like I could punch in those drugs and I could get the information. I didn't have to memorize all the different metabolic pathways, or this one's renally clear, this one goes through this liver pathway. Where my predecessors, they did have to know that because it was too cumbersome to carry around volumes and volumes of textbooks to try to find that answer and to run that interaction checker. We're encountering the same issue here, I think, with a lot of our AI models that our students use. Like you're saying, with these assignments, it's great that they can use this. I love that they have the opportunity to have so much information available to them. The challenge we're having is, how do you not let that get in the way of education? They have to understand what evidence they can trust, what evidence they shouldn't trust, and where errors might occur in that whole process. It requires a ton of understanding of the nuance and the context. And if you don't feed that nuance and context into the machine, you won't get it back out. And whatever you do get back out, you have to now apply in the context of your patient, who's a person and not just a piece of paper or a feed that you gave to the AI model. And that's become really challenging because for me, well, I was, trained into this model where I have access to all of the data is on my phone or on the computer, and that's fine. But I still had to figure out, where would I go to find this data? What's going to get me the right answer, and how would I apply that? What these models now are doing is mimicking really well how you do that. Some of them are better than others. And to a novice student, they can feed that into the machine and they don't know what they're getting back out. It reads just like what you'd think any other, professor or physician or nurse would provide back. And it's like, well, what is that good? If I just give that to the patient, you might really miss some important things. And that's been a real challenge, I think, for as we're building our courses. How do we make sure that our students can use this technology, because it's only going to get better and it only really kind of improves your ability to provide care, but you have to have that fundamental ability to analyze that stuff. And it's been a real challenge.
Well, it sounds like Roseman is leading the way And I love that all of you are sort of very abreast of all of these new advances that are taking place and incorporating them in each of the schools and each of the colleges. Definitely our students, all of our students, I look forward to what they do over the next few years with all of these advances coming in. So I'm going to ask two more questions, but the first one is really more around, okay, to pharmacy, nursing, and dental. You now have a College of Medicine. Yay. So my question is really, how do we begin to do more things? I know we have the IPE, but let's talk a little bit more about what does that look like in real life? Like, what does it look like when there's a boatload of students, all from all these different areas, coming into one giant campus in the next 5 to 8 years? How are we playing together? And are we playing well together?
Excellent question. And I appreciate that you noted that pharmacy has been pushing interprofessional education, or IPE as we call it, for several years. The College of Pharmacy established directors of interprofessional education back in 2018. Part of this is driven by our accrediting bodies. Pharmacy has kind of pushed interprofessional education into the curricula of all the colleges of pharmacy across the nation. And so Roseman's really kind of taken that initiative and built great community partnerships with our dental medicine program, with our nursing program, reaching out to Toro University. It has a DO program. And I think that we are super excited to have our own in-house MD program that we can coordinate with. Beyond just these interprofessional education activities, the resources that the College of Medicine is going to bring in terms of researchers, in terms of standardized patients, simulation, all of that stuff is actually going to really improve the quality of education we're going to be able to offer to our students. It's just a whole nother giant pool of resources that Roseman's really investing in. And we are so excited to be able to use some of those and work together collaboratively to build the best students, physicians, pharmacists, dentists, nurses going forward.
Love it. Nursing. Well, because she doesn't have students.
Yeah.
She might have a theory and yes, but
Just wanted to make sure you were.
right.
So one of the other things that I've seen that brings all the disciplines together was the research conference that we had this spring, where I got to be a judge, but I didn't even judge any of the nursing posters. I got to judge some of the other posters from the dental school and from the pharmacy school. And so I think that brings people together. It was a half day and then there was speakers and that sort of thing. So that's a wonderful approach. And so I think expanding, more of that kind of thing, like interprofessional things that we do together that could involve, looking at each other's studies, and then also possibly even doing some studies together, maybe some research together, because that's one of the things I appreciate about Roseman is the collaboration with the research that we do here. So, expanding our research and continuing to do more of that. And also possibly continuing to the classes that we have, expanding the IPE. Could we even do some classes together that
Mhm.
will teach us about teamwork and multidisciplinary care? That's another option as well. But to expand what we're doing already, because we have so many things that we're doing well already, and how can we share it with each other?
So, I mean, even before College of Medicine became accredited, I mean, while we were, I was like chomping at the bit to, and as soon as you guys open your door, that's why I'm always bopping around the College of Medicine. And, I would kind of, we've done stuff together, Steve, Joe, we've all kind of, looked at, based on what the literature says, that when there's increased lines of communication between different healthcare providers, patients get better care, period. That combined with the fact that there's a lot more research out showing that there's systemic connections to oral health, which we've always known, but it's becoming more appreciated now. There's a lot of systemic conditions that affect and have oral manifestations. Sometimes they're the first manifestations, and vice versa. You know, the like classic one is the connection between cardiovascular disease and periodontitis. So we're already kind of looking at what that's going to look like, and we actually just built a 9 or 10 bay primary care medical clinic within our dental clinic in Henderson. So one of our clinics in Henderson, which is our biggest kind of general dentistry clinic, we have about 8,000 active patients. Over half of them do not have a primary care physician, right? And so we've partnered with the Roseman Medical Group, which is Roseman's primary care model, to actually build a clinic within. And so when you go in there, it's a shared waiting room, a shared front desk, and a shared EHR eventually. And so that all of this information is already kind of fluid and natively accessible to everybody. It's easy to kind of get those kind of lines of communication open. And then we do the same thing with Cure for the Kids Foundation, which is a foundation that provides medical services to kids with rare childhood diseases and cancers. And so we actually round on the patients with our colleagues, our oncologists, and our hematologists, and our immunologists. And it's awesome. I could just keep talking about it, but yeah.
Yeah, great. Thank you. Not to leave you out, Dr. Neely, you're going to start with this last question. And I want you to be, I don't need to tell you this, I want you to be bold in your thought. Be bold in your thinking. What is one change or investment you'd like to see at Roseman so that we can build better healthcare workforce for tomorrow? If you could just wait, each of you get to think about this, because we can make a list and, you know, send it to Dr. Kaufman later. What is that one thing?
So the thing is, that's such a difficult question, and here's why. Because everything that's kind of on my wish list, we're doing. So, we're really kind of on the right path. I think a lot of my sort of concerns or things that I would change aren't really, they're tied to the healthcare system and less like Roseman, right? But I would say that we have great community partnerships, but I think more community partnerships and sort of, even broader and yeah, that's like the toughest possible question you could ask.
Okay.
That's like the toughest
I
possible question.
cannot believe I stumped you.
Yeah, I'm so completely stumped. Very stumped.
I'm so glad this is recorded. And I have witnesses. This is insane. What's your big wish or investment that you want to
Okay,
see
well, I
happen?
have a couple of them, so
Give me the biggest one.
I'll be short. So I think helping cross economic barriers where we can provide more scholarships for students.
Okay.
I know our dean, Dr. Oxhorn, is working on a HRSA grant to provide scholarships, more scholarships to nurses with Dr. Dillon. And so I think just kind of focusing on that, because that's huge. I mean, as we all know, student loans are a big deal. And so if we could help with that, and then my other wish is to expand AI and that more in nursing education, because some of the other disciplines are even further ahead than us. Okay, who's next?
Who wants to go next? I'm scared of you.
You said bold,
I'm
right?
really scared of what you're gonna say, but go for it.
Is it bold?
Bold.
All right. I think we should reopen the Roadrunner Cafe.
Oh, hey,
So
right.
I'm gonna be logged out of my office tomorrow now. But no, I would say I would honestly like to see, and I think we're already on that trajectory. I'd like to see us, not really dipping our toes in the IPE realm. I want to see it like in action. I want to see, we're already doing stuff. We already collaborate. You help us teach our students venipuncture, and we're working with pharmacy to try to, get some patient review going with our medically complex patients that are like polypharm and taking all these crazy drugs that I've never even heard of in my life, and all that stuff. But I think that's what I'd want to see, is to actually put that into an actual practice and get it
Yes.
in, like in front of the patient.
Yeah, love that. Last but not least.
All right. I don't want to speak on behalf of pharmacy because I think there's a lot of faculty and there's a lot of things that different people might really wish for. I will say nursing, I really appreciate the more scholarship opportunities, ways where we can get more people into the profession. Personally, one of the things that I am looking forward to, because I think we're moving in this direction as far as expanding the campus here and kind of building that out, I would like us to have more undergrads. I would like to build an undergraduate pipeline for all of our graduate schools, expand out the College of Nursing and have other prerequisite courses, like almost like a full, all the offerings. I think Roseman has a unique model that would be adaptable for a lot of these other undergraduate courses. And I think inculcating our students into that model from fresh out of high school and then moving in through all of these health professions, I think that sounds to me like a really awesome opportunity. We could build out the campus here and have more undergrads. That is something that I think would be interesting if I had one wish.
That is bold. That is bold. I want to thank you all for your bold ideas. I just have one wish. So you guys know about Aspire. Aspire is our pathway program at the College of Medicine. I want us to work more together. So when I call y'all and we have events, it is awesome when I've worked with some of your students in pharmacy. They've come to our events. I've worked with nursing. I've worked with Dr. Thacker and Dr. Chin. I love it. So, but I want to see your students out there. The students are the ones that the kids get excited about, want to talk to about their journey, and learn more about each of the schools. I know medicine. That's it. So if they want to know dental medicine, I'm like, yeah, Dr. Thacker, because he's the one, or someone in dental medicine. So I would love us to really collaborate a little bit more in building that pipeline and that pathway for kids in the Valley so that they have the opportunity to see all the great things that each of the colleges has to offer for them, because everybody can't be a doctor, but they all think doctor, but I'm like, no, we have options. And so I want us to collaborate more. That would be my one big wish.
So the kids said that they didn't want to see us, they wanted to see the residents and students.
I mean, y'all are all right, but they don't want to see me either.
Which school?
They don't want to see me either. They want to see students because the students are closer to them and they actually can see that, oh, there's a person that looks like me and they're closer to my age than me. And, when I went to undergrad years ago, it was different. We didn't have iPhones. I will say that. So with that said, I am going to open up the floor for questions. And we are going to, I think we only have one mic. Do we have another mic? Because we got to have another mic. Oh, all the mics are up there. So this is what I'm going to do. I'm going to take the mic and I'm going to pass the mic and then I'm going to pass it right back to whomever is going to answer.
This is a quickie. The Roseman method, is that the 90% plus to progress model?
Wait.
So especially with College of Medicine coming into the fold, it's about competency. So, say for example, you were, and I'm going to give this example that's a fairly, widely used one. So it's not, I don't claim ownership of it. But if you were to go birth a baby, you couldn't birth 60 or 70% of the baby. You kind of have to birth the whole baby, right? So even 90% of birthing the baby, you haven't quite succeeded. And so I think one of the things that Roseman has really focused on is sort of a competency-based, evaluation. And so we are going to have things that are, very competency-based, where you absolutely have to be able to do it to get to the next stage in medicine. I do think that because the way medicine is, our assessments per se will have fairly, we still have a lot of competency-based things within that, but obviously our board exams and some of our summative exams will not be at that 90%. Yeah. 90, yeah.
Yes. Okay. Oh, is that on? Okay, perfect. You guys can hold that.
Good evening. I came to the College of Medicine originally from the East Coast in a state that had a lot of magnet schools in the public school system. Does Roseman have any plan to do a healthcare magnet school? So it was Charlottesville, Virginia, and one of the things UVA created, sadly, the kids in the program were called hamsters because it was HAMSA, Health and Medical Sciences Academy. So the poor HAMSA kids, and they went with it. They adopted a hamster with a little stethoscope. It was awesome. And in my field of medical simulation, like all of our equipment that aged out a little bit, we donated to them because they could really use it. So we had kids in high school within a regular public school who were doing health and medical sciences. They got everything from Greek and Latin to all kinds of things, internships in the community, and all kinds of pre-med courses, anatomy and physiology, you name it. So is Roseman looking at doing anything like that with magnet schools?
Yeah, we're starting with the durable.
Anyone want to take that?
Well,
Okay, so I do know that there is a design in that space. I know Harry Rosenberg, Dr. Rosenberg, has an idea of something that he would like to see that once everyone is sort of, I don't know if this is public knowledge and I'm just blowing it up, but there's a thought about something like that occurring so that we can have feeder schools and grow our own healthcare workforce.
Yeah, I think speaking to that, like when you were asking, like, what would you want to see? And I was like, well, all the bold ideas, like we're really planning to do so many of the things that you could ask for, I think is on our roadmap of things that we are trying to do. And so, I mean, for now, we're starting with the Aspire program and sort of building that up, but it's broader than that. The vision for that is definitely broader than that, and it's in that direction. So we don't maybe necessarily have one right now other than our current programs, but that's the vision.
Thank you for. Yeah, yes.
Okay. It's so good to hear the evolution of the medical field. I am a graduate 1965 from the University of, Santo Tomas in Philippines. I came here to the United States for postgraduate after, internship and everything in 1966. So I've been retired for a long period of time, but I long to update my knowledge, to get all this, excitement that is, going on, especially with the scary AI application. One thing that I'd like to emphasize is that if you have the students emphasize the fact that take the whole patient, holistic aptitude, and not, part this, because that's to the subspecialist.
Right.
And the other thing too is that we were trained during our, schooling and, during the pre-med 2 years. And then we have the academics with the basic sciences. And then we have clinical, during the 3rd and 4th year, and then internship. What the emphasis is that you start evaluating your patient the moment they are coming into your clinical area. And then that's inspection. And then the next step is, after the history, of course, complete history, And then, the second part of examination is palpation. And, I have a initial evaluation of each patient, and I was at the VA. But my training, my, residency is OBGYN. Can you beat that? They try to come to the VA to deliver the babies, but I said, no, I don't have any pediatrician. I don't have any neonatal unit that I can put your baby. But going back, the next step is auscultation. Okay, we learn what is the different sounds, different murmurs and everything, which is still going on, which is good. And then we have the palpation, percussion. And the percussion, when they're just like the drum, and that's gone. You go to, I see your doctor right now. They just look at you and then head, neck, and thorax, normal. I said, you never examined me.
They never touched you.
There is already a sheet that is already for, check, 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 check. Normal, normal, normal. That's not the way to practice medicine. You cannot diagnose a disease without those examinations and coordinating the findings that you have in each region.
Well, I can promise you, solemn promise,
Uh-huh.
that graduates of Roseman University College of Medicine
Uh-huh.
will palpate and auscultate and inspect and percuss. Because again, that's the humanistic aspect of medicine that the AI cannot replace, right?
There's no substitute for that.
Yeah.
But there is so much consciousness about like privacy, sensitivity, and you have to examine the patient, of course, with someone beside, in order that you're not going to be accused of, abusing the patient. The other thing too that, I dislike is that, when I was in practice, they expect me to finish evaluating the complete patient 10 to 15 minutes. Okay, in the VA, that's not applicable. I always complain to my boss. I said, how can you expect me to have a GYN patient, from the examination and the other evaluation, the orders, and then the plan of treatment? I said, that's not for me. So usually I have like a patients waiting for a long time in the waiting room. I said, if you want me to really find out what's going on with you, you need to, stay. Because it doesn't, it
So-
doesn't substitute.
I will jump in here and say my bold request, which is the one that's not in Roseman's hands, is really that, right? For us to transform the practice of medicine, and really to reimagine how medicine can be done.
Mhm.
And it's really, for me, it's really a misalignment of incentives that sort of
Yes.
financially incentivize these things. And these determinations and these things are not driven by the physician. There's no physician who enjoys this, right? And there's no physician who would want this, right?
Yeah.
And so that's my bold ask, which I don't think our
I got no
president
control.
can achieve for us,
No.
as powerful as she is. But hopefully over time, we are able to, I hope that my role at Roseman will be to help inspire a generation of physicians who will solve the problems that I cannot. And this is part of that. And I think if we inspire them with that humanistic spirit, then they will be the flag bearers for a different type of medical practice, and
Yes.
they can take that out and reimagine what this can be. Because the way healthcare is running right now is not sustainable. It's going to have to change. But what that looks like, I will say it's just far beyond what I can anticipate.
Yes.
And so it's going to have to be a collective effort for us to make those changes. But I will say that we are committed to being part of that.
Thank you.
Well, salamat po for the question. Um, I think a lot of that is, you worded it perfectly. The misalignment of incentives. Yeah, I forgot the last word. Sorry. But at the end of the day, unfortunately, it comes down to money, especially in the dental space with the astronomical tuition that these students are paying. And then second is just I know it's kind of controversial, but just the corporate nature of where dentistry and especially, medicine kind of led the way in that aspect in a bad way, kind of, and in dentistry, we're following suit and so, at least at Roseman, we are, when our dean moved to a 3-year program, he basically refused to move forward with that unless the school could guarantee that we would not raise tuition. And so by doing that, we basically cut tuition in a fourth. Still got a long ways to go, but yeah.
So we do have a question in the chat, and it's asking specifically about the College of Medicine. What do we envision our first class to be? So we are in that process, and we are selecting our first inaugural class. And we are taking a holistic approach to our student selection. We are, as Dr. Akumili kind of alluded to, we are really focused on ensuring that we are meeting the needs of our Nevada residents. And that's not to say we're not going to take out-of-state students, but we are really trying to get students to understand that if they are not a Nevada resident, that we would love for them to set up shop in Nevada, right? Because we know that there are needs here that are unlike any other place. And so that dedication, we are looking for students that are community oriented, have a strong sense of service, because a lot of the work that we do is community based. All of our programs are community based, from our curriculum to our pathway programs, to our other programs, empowered, like we are in the community, right? And when you go out in the community, people know Roseman, right? They know who we are because we spend so much time in the community. So that is what we're looking for in students. And I do have the Director of Admissions. Would you like to add anything to that?
Student.
Awesome. Hi, everyone. My name is Moises. I am the Director of Admissions for the College of Medicine. It's been quite a journey, and the best way to kind of describe it is the members of the admissions committee have some of the best discussions about what it means for a Roseman University College of Medicine student. And the best way to describe it is last fall we did a outreach event with Shine the Light, and we were able to go into the tunnels with that organization and meet some of the unhoused individuals. And it was a really eye-opening experience for myself, and I know some other members of the committee. And every time we're having a discussion, the conversation comes up, would this student be in the tunnel with us? Would this student provide care for other individuals in that situation or other scenarios? So that's always been at the forefront of every discussion in how we screen applicants and who we interview and who we ultimately have admitted. So it's been quite a journey, but the faculty on the admissions committee, the College of Medicine has been extremely committed to finding students who will be in the tunnels and supporting our communities.
All right. Any other? Yes, one last question. The floor is
First of
yours.
all, I'm just very impressed with you guys. The one board game called Taboo, has anybody ever heard of that, where you're supposed to say a word, but you're not allowed to use any of the common words? I know the diversity, equity, and inclusion are kind of the words that you're not supposed to use, but congratulations on just pivoting to just an amazing, the future of medicine, education, and technology. So I'm just very impressed that you had that sort of scramble I get a
I'm
guess
good
at the
at
last
scrambling.
minute.
I'm good at that.
And
I am
wow, great job on
Queen
just
scrambler.
very impressed with Roseman. So good job. Thank you.
All right. Well, thank you all so much for being a lively audience, both online. Oh, wait, hold on. There's 2 people in the chat. Let's see what they're saying. Oh, thank you. Okay, you're welcome. So thank you all so much for engaging with us. I want to thank my panel. Please give it up for the panel. And I want to thank you guys for actually saying yes. I think this was an awesome first time. I feel like we could do this on an annual basis because I think change occurs quickly. And I think the community needs to see and know what we're up to, and that we are fully transparent with the work that we're doing both in the community and amongst ourselves as colleagues. So I think this is really important for the future of healthcare for Nevada. Thank you all. Oh my God, thank you so much. Exit me, what do you want?
Like, I can't even.
Staying alive?